for the medical students, so all graduating residents have to do a grand rounds as part of their requirement of residency. And so Dr. Ramona Dsouza is going to be talking today about oral health and pediatrics, and this is a very timely topic because the American Academy of Pediatrics is really focused on oral health, partially because kids whose teeth hurt and mouth hurt don't do well in school. And so that's one of the reasons why we're focusing on that, and that's one of the reasons why this is going to be a great lecture this morning. So, Ramona?
Thank you, Dr. Cooper. Good morning, everyone. Can you hear me? Yeah. Thank you, everyone, for being here this morning for this lecture. The reason I chose oral health in pediatrics is because oral health is an important part of a general well-child health visit. It is important, but it frequently gets neglected in the grand scheme of things in a busy pediatric clinic. So I thought it's important to talk a little bit about oral health in pediatrics and its importance. When we were doing our quality improvement project for this year, and I looked back through my charts to see how well I was doing at tracking oral health, it dawned on me that I wasn't doing too good a job. So this preparing for this grand rounds helped me take a better look into oral health, and I hope you all get a little bit from this today too. Okay, I have nothing to disclose. My objectives for today is to understand the magnitude and the impact of oral health problems in pediatrics, to discuss a few common oral conditions and abnormalities that we see in everyday clinic, and to talk a little bit about the prevention of oral disease, which is actually the main focus of oral health in pediatrics today. So moving on to our first objective, understanding the magnitude and the impact of oral health problems. A few fast facts to really tell you how important this issue is. In 2009, there were about 50,000 visits by children to emergency rooms for preventable dental problems, and only 2% of children have really seen a dentist by their first birthday, and about 51 million school hours are lost by US children each year because of dental diseases. Our Surgeon General in 2000 actually described dental diseases as a silent epidemic that's affecting children of the US today. So dental caries is often the most common chronic childhood disease. About 42% of children in the age group of 2 to 11 years suffer from dental caries. 50% of our teenage population, the 12 to 15-year-olds, have dental caries. And an interesting fact that I learned, was dental caries are actually 5 times more common than asthma, one of the most common chronic childhood diseases. So it's really important for us to kind of take a look into those mouths and kind of look for those dental caries. Traditional curative dental care is a significant economic burden for many high-income countries, where you're actually spending about 5 to 10% of your preventative public health expenditure on oral health, but in the end, it's not being used towards prevention, and you end up going to dental offices and spending a whole lot more on curative practices. So this is from the National Survey of Children's Health in 2007, where it was a random survey where they asked parents about how they felt their kids' oral health status was. So it was a subjective survey. What this really kind of emphasizes here is a lot of kids in the lower poverty, that's the federal poverty level. So those kids who were below the federal poverty level, about 50% of our kids, the parents reported that their oral health condition was not good. And as your economic status improves, your rating of your oral health status for your kids improve. And so that really emphasizes that it's really the minority population, the Hispanic, the African American population that you have to focus on to really make sure they're getting that accurate dental screening in place. When the same group of people were asked, the group of mothers were asked as to what was the most common oral health problems they had in the last 6 months, the top 4 were the decayed teeth or caries was number 1. complaining of a toothache with stew, broken teeth, and then bleeding gums. So those are some of the most common oral health problems that were encountered. This talks about a little bit of the prevalence of dental caries in your primary teeth by age and race. And what we see here is dental caries experiences both treated and untreated dental caries. The experience has been the highest for the age group of 6 to 8 years, which is around 55%, and slightly lower but still marginal, 22.7% total dental caries experience. Again, the race population that this really is highest is in the Hispanic and the African American population, and the prevalence rates are similar for the untreated ones. And this talks really about the primary teeth. When we move on to the prevalence of dental caries in the permanent teeth by age and race, the prevalence rates are similar to those in the primary teeth, just slightly lower, but still, the highest age groups are between the 9 and 11 years, and again, the race prevalence that is more is the Hispanic and the African American population. So closer home down in Louisiana, when this was a survey done in 2011 about children's oral health status and how parents rated it. The general average in the United States was about 81%, with they said no oral health problems. We were pretty close, 78% no oral health problems. And then one or more oral health problems, which again include dental caries, bleeding gums, toothache, were some of them that were asked. In Louisiana, it was about 22%. Generally, it's about 18%, pretty close to our national averages. But be mindful that these were all subjective. So it was asking us about how parents rated their kids' oral health. And so looking back at this journal in 2012, the American Dental Association, they actually wanted to rate, because a lot of our oral health ratings and articles come on subjective experience about what the parents think the kids' oral health is. They said there's very poor clinical correlation between a parent's assessment and real clinical needs. And that's specific for children under the age of 2. It's vastly underestimated. So non-oral health professionals like pediatricians, nurse practitioners are the first to see these kids in those first 2 years. So it's very important for us to get a better understanding of oral health care needs in this population. As far as training is concerned, was published in Pediatrics in 2004 about educating pediatricians on children's oral health, the past, the present, and future. And this talks about the level of oral health training, and they said it's really inadequate based on what the training of pediatricians and the undergraduate, graduate, and CME levels. It's inadequate to provide them with the competencies required to perform adequate quality oral health care. So looking further into that, there was this role of the pediatrician in oral health care, which was a national survey in 2000. What they did was they surveyed a group of pediatricians, about 1,700 from the American Medical Association. It was a random mail-out survey. They asked them a couple of questions. Some of the key learning points that they had from that survey was about 40%, close to 40% respondents of pediatricians said they had received no education in dental health in medical school. About 42% said in residency, and 60% said through CMEs. So really there was a lacking in receiving any kind of dental education to perform good oral health examination in these kids. The average number of years that these pediatricians they were about 13 years into practice, and they had about 40-hour weeks. They would see about 40% of the kids were in the age group that targeted the dental caries age group. The other question the survey asked was about the knowledge and familiarity with preventative therapy. What's important is these were just knowledge questions. Only 9% of this 64% that was surveyed actually really answered all these questions correctly. So a lot of us then got the questions about only bottle-fed infants get early childhood caries, which is definitely false. Only about 78% got that correct. 3-month-old babies living in non-fluorinated area need fluoride supplement. About 40% of them actually got that wrong. Because and we're going to talk about this later as to why that's wrong. Another interesting fact was about 60% got this question wrong. Where cavity-causing bacteria can actually be transmitted between mother and children, and that's something that we need to really look into when we see our kids at our wild child visits. A final point was dental sealants are usually applied to children's primary teeth, which is false, and again, a lot, about 60% got that question wrong too. So there was definitely a lacking in knowledge of preventative dental practices in this group of pediatricians that were surveyed. Another part of that article was, what about the current anticipatory guidances that they had implemented in their clinic? They were very likely to ask about bottle to bed. A lot of us do that, examine children's teeth for cavities. Important again to notice that only about 7% of those surveyed really inquired about the mother's dental health, which is very, very important. And we'll see why as we talk a little about later on into risk assessment. They all strongly agreed, though, that assessment for dental problems should occur during child care. You have to counsel on prevention of dental problems, and not so much of a consensus response about application of fluoride varnish, which again we'll talk about later on as to why that's really very important, and about referring the child to the dentist by the age of 1. So we all know there are a lot of consequences of poor oral health, but some of the most important ones are really premature loss of your primary teeth could predispose to different kinds of malocclusions. It could predispose to impaired speech development, failure to thrive, reduced self-esteem as they progress through adulthood, and difficulty sleeping with some of the most common consequences of poor oral health. So having gotten a look into understanding the magnitude and the impact of this problem, we're going to go ahead and talk about a few, not all, it's a very comprehensive topic, so a few common oral conditions and abnormalities that we see in pediatrics. Very important to understand the tooth eruption cycle. Always remember primary teeth eruption is symmetrical, occurs in pairs, usually proceeds from the front to the back. It's always mostly the upper teeth versus the lower. They usually should start erupting around 6 months, but anytime between 5 to 10 months is okay for a primary tooth to arrive. Eruption is completed between 24 to 36 months, so a lot of our kids at around their 2 to 3 year visit would have about 20 primary teeth. And around 5 to 6 is when the teeth start getting loose. And that's around the same time that your permanent teeth start erupting. So that's the age distinction between primary teeth and permanent teeth is around the 5 to 7 age group. And then your permanent teeth start are finally erupted by about 13 to 14, and then your third molars, your wisdom come much later. The pattern of emergence is similar for primary and permanent. You start getting your central incisors first, followed by lateral incisors, your first molars, your canines, and then your second molars. Whereas permanent teeth, it's just that your premolars erupt before your canines, and then it proceeds in the similar pattern. So what happens when kids come in and they're talking about delayed primary teeth? They still haven't had their tooth erupted between that period of 5 to 10 months. Most often, it may just be a general non-pathological delay, but you have to always keep in mind that there may be some oral space issues. Is this a problem of crowding teeth, that there's no space for those primary teeth to erupt? A common thing sometimes is just dense gingival tissue. In some kind of dental infection in the tooth that has not erupted as yet. Some of our kids who have early therapy, radiation therapy for some forms of cancer can also have delayed primary teeth eruption. Certain form of endocrine disorders and genetic disorders can also lead to delayed primary eruption. So you have to always bear these in mind if that first tooth hasn't erupted in that timely period of when it's supposed to. But importantly, the American Academy of Pediatrics says that dental referral is reasonable if you've seen no tooth erupted by 18 months of age. So a lot of our kids who come in at 7 and 8 months, you can always tell them we still have time to wait. As far as tooth exfoliation, what about tooth loss? And when do they get visited by the tooth fairy? So early tooth loss really is most common either just from dental caries, any kind of trauma. Again, endocrine disorders, immune disorders do play some kind of role in early tooth loss too, if the above two weren't a factor into tooth loss. Important also to note is the delayed loss of primary teeth. If your teeth are not, they normally fall by 5 to 6 and he's still having his primary teeth in, Think about endocrine disorders like hypothyroidism, hypopituitarism, because these can present with some delayed teeth loss. Vitamin D resistant rickets, ectodermal dysplasia, which is just a display abnormality in the eruption of skin and its other appendages like hair, nails, teeth. Some genetic disorders that do play a role in delayed exfoliation is Downs, Apert, osteogenesis imperfecta, achondroplasia. Rare conditions, but just to keep in mind, most of these get detected much before just the delayed exfoliation phase. So few things seen in our newborn period, natal and neonatal teeth. We see these sometimes in the nursery. Generally, research says no treatment is indicated unless that tooth is like a little unstable and mobile, because you don't want them to kind of aspirate on that tooth. Unless it interferes with breastfeeding. And so with the constant back and forth thrust of that tongue, it can also lead to what's called the rigor fade ulceration. And so those are reasons where you want to extract these neonatal teeth. The natal teeth are when they're born with those teeth. The neonatal teeth are when it erupts in that first month of life. And typically these are primary teeth. They are not the supernumerary teeth. Most of them are immature teeth versus the complete maturation. The most common reason kids have these neonatal teeth is just the placement in the gingival tissue. They're just closer to the edge than normal, and that's why they have this eruption. Another common condition we see in the pediatric clinic sometimes is when you open those mouths real wide, you can see some of these little white papular lesions located in the hard palate, at the junction of both the hard palate. These are called Epstein pearls. Occur in about 75 to 80% of our newborns. They're just trapped epithelial remnants. A condition very easily reassure mom, it's going to go away. It sometimes goes away by 3 months. Another condition similar to epithelial remnants is actually called the dental laminar cyst. Now this occurs along the alveolar ridge. It's at the site of eruption of the tooth. They generally occur singly. The Epstein pearls occur generally more in groups. It's also called the gingival cyst of the newborn. Typically self-resolving, it goes away within 3 months, but sometimes it can interfere with feeding, it can be painful, it can get infected. So these are things you want to make sure you kind of keep an eye on and make sure it resolves. Bones nodules were frequently mistaken with Epstein pearls, but actually they are a remnant of salivary gland tissue, the minor salivary gland tissue. The important thing to recognize about Bones nodule is to differentiate it from the natal neonatal teeth. They typically occur towards either the labial or lingual surface of that alveolar ridge. They do occur in pairs, and they also self-resolve by 3 months. So these are just benign conditions seen in the newborn period. Another important thing, but very rarely seen, but important to distinguish because this would require a referral, is the congenital epulis of the newborn. And what this really is, a cyst-like lesion in the floor of the mouth. It's called a granular cell tumor of the newborn. Another name they call it is Newman's disease. It is benign, but the important thing about this, it could affect feeding, it could affect, sometimes they're pretty large, it could affect breathing too. So this would require a surgical evaluation, possible excision. Important to know that once excised, it does not recur. Majority of the time it will not recur, so it's benign. Eruption cyst hematomas are these that arise again at the site of the tooth eruption, typically filled with clear fluid. It becomes a hematoma when, because of trauma, it gets filled with blood. Again, self-resolving, but these also have a higher chance of getting infected. So if these do become painful or tender, you may want to kind of de-roof these cysts and make sure that it's not persistent. Moving ahead, and a final important thing that I thought was important in the newborn period is tongue tie, ANKYLOGLOSSIA. Just because we're all moving over to the breastfeeding initiative and making the hospital breast friendly, I feel a lot of our kids need a more proper evaluation of the tongue tie, because a lot of our mothers say breastfeeding could be painful, there's poor feeding, there's decreased weight gain with kids, and that's really because of the way the lingual frenulum is holding that tongue down. Now, if it's not detected earlier because of any feeding issues, there's just mild tongue tie. Sometimes speech gets affected, and this you start noticing around the age of 3, where speech articulation problems like L, R, T, D, those are the words that they cannot pronounce too well. Older children may have a gap between those front 2 teeth because of the attachment of the lingual frenulum. And some of them have that V-shaped notch at the tip of the tongue. What's really important to know is that there is a scaling tool for whether you want to go ahead and recommend that frenotomy versus frenulectomy. And it's called the Hazel-Baker assessment tool. What it does is it looks through the function and appearance item of the tongue and the way the lateralization, and the way you do it is really score the kid, take your finger, move it over the alveolar ridge, watch the direction or movement of the tongue. Sometimes when you stroke that lower lip towards the chin, they protrude the tongue more and see how far out that tongue could extend. So under the function items, they have lateralization, the lift of the tongue. So when you try and touch their palate, they try to move their finger towards the palate and see how high that tongue could rise. Extension of that tongue beyond the lower lip is very, very important to see how far it could go. And then based on this, there is a score, and depending on whether they do very well on it and where they fall, they could be referred for a frenectomy. Teething is, well, we all know a very common problem that they come up with those first teeth. It's very non-specific symptoms: irritability, drooling, mouthing objects, sleep disturbances, biting, ear rubbing, rashes, a whole series of non-specific complaints. And what research really shows is just drooling and mouthing of objects are really specific to teething. Most of them are could be associated with teething. We all know cold items really, and just cold pacifiers, not frozen but cold, just because cold acts like the anesthetic for the gum, should be used. A lot of our parents still sometimes use the Oragel, the Highlands teething tablets, and so we have to constantly caution them against using these over-the-counter products. The Oragel has something called the benzocaine, which can, in excessive exposure, cause methemoglobinemia. So bear that in mind. And then the teething tablets were homeopathic tablets that people use. They dissolve them in a little bit of water and put it on the gums. But you have to be aware that this product, actually the FDA had found some traces of belladonna, which is an alkaloid, and that is an anticholinergic. So if you overdose on those kind of pills for teething troubles, you land up with kids having dry mouth, flushing, coming in with signs of anticholinergic crisis. So definitely no Oragel, no teething tablets, just a good time to actually reinforce the use of correct doses of Tylenol and Motrin with these kids when they come in, if needed. We spoke about dental malocclusion a little bit in the beginning about some of the consequences of poor oral health. Now, dental malocclusion actually can be skeletal versus dental. Skeletal is when your jaw is misaligned to your the face, and dental is when the upper jaw is misaligned to the lower jaw. What's important to know really about these malocclusions are there two types that are preventable in pediatrics. One is caused by premature loss of primary teeth, and that's when we have to really kind of get them to see a dentist and maybe put in a space retainer there. The other type of malocclusion that is really preventable is the one that's caused by the non-nutritive sucking, the kids that are suck onto those pacifiers and they thumb. So the non-nutritive sucking, really 70 to 90% of infants will have a history of non-nutritive sucking. Most of these kids, they discontinue it by age 2 to 4. Children who suck on pacifiers, remember, discontinue it at an early age than those who suck at their thumbs. So the thumb suckers are the ones that you really want to pay attention at your well-child visits. Make sure they break that habit. And the reason being that if they do so before the age of 3, the effect on their developing teeth is really limited to just change in some incisive positions. But once your permanent teeth erupt, and if that thumb sucking continues, there'll be a lot of issues with malocclusions. And some of them that you see with persistent non-nutritive sucking at the time of eruption of your permanent teeth, you have kids come in with this anterior open bite where your incisors don't touch each other. And this is a common condition you also see in kids which are habitual mouth breathers. So a lot of our allergy kids with enlarged tonsils, adenoids, frequently open mouth breathing, a nice way to evaluate them is actually look at that jaw occlusion sign and see if they have that open bite. Posterior cross bite is something, again, it's not really visible well here, but it's again something that happens with habitual, prolonged pacify and thumb sucking. Your posterior mandibular and maxillary molars actually tend to not oppose, which is what the ideal position is. Your maxillary molars are more towards the lingual aspect of your mouth, so they're inwards versus being opposed. And this is also associated with maxillary constriction because of the narrowed space caused by that persistent thumb sucking. So some things that you could evaluate in clinic for dental malocclusions. Now, what are the interventions for non-nutritive sucking? Really, before the age of 3 is just kind of talk to the child, place reminder therapies, reward therapies work with kids. Sometimes they physically interrupt the habit. Some kids kind of put a little bit of a some parents put bandage, put something bitter on the tongue, on that finger that they suck. They also little thumb guards that they use on the most common finger that kids suck on. But if you cannot cannot interrupt this habit before the eruption of those permanent teeth, the American Academy of Pediatrics feel that initiating a dental referral by age 3 is reasonable. Moving on to dental caries, the most common childhood oral condition in our clinics. And what dental caries really is, it's an interplay of the 3 factors: the teeth, the teeth, the cariogenic bacteria, and the fermentable carbohydrates. So whenever you eat any kind of sugary, carbohydrate-filled meals, the bacteria in your mouth, which is the most common being the Streptococcus mutans, they act on the carbohydrates, break it down, and form acid. What that acid does, what happens is then your pH of your mouth starts. The pH of your mouth starts to fall, and when it falls, it's more prone for your teeth to get demineralized. So why we often tell our kids not to frequently snack every hour or every 2 hours, because once you eat and you form that acid and the Streptococcus acts on that acid, the pH falls, and it takes about 20 to 40 minutes for that pH to regenerate back to the baseline. If they're going to eat another snack, what keeps happening is that pH just keeps staying below the baseline, promoting those teeth to frequent demineralization. So to enhance remineralization, we need to have those teeth at a baseline pH of about 5.5. And that really is by promoting just 2 meals, 3 snacks, but no frequent snacking. So what are early childhood caries? Early childhood caries were more often called the baby bottle caries, the nursery caries. It's really when you have 1 or more decayed, missed, or filled tooth surfaces in any primary tooth under the age of 6. So really focusing on your primary teeth. They tend to affect, and this is something that we could look for, is the upper maxillary incisors first, because these are the least, they erupt the earliest and the least protected by saliva. The canines tend to be spared most often. They're smooth teeth, they erupt later. So really when you want to look for those early childhood caries in kids less than 6, look for those upper maxillary incisors, because that's where they tend to start. So early childhood caries actually occur in a couple of stages, and the earlier you pick it up, the better. So these are what is the stage where you really want to identify these. So always lift those the lips up, look at that gum line. Sometimes you get to see white chalky deposits at the gum line, and that's really the initial stage is stage 1. This is a kid who's progressing from stage 1 to, you can see a little bit of more demineralization, forming a little brown pit there. And as you move further, you'll see a lot more brown pitted surfaces on these teeth. So once it reaches this stage, it's essentially non-preventable. So and then these are really bad carious teeth. So the time to really pick up early childhood caries before the age of 6 is to lift the lip and look for those white chalky deposits on those incisor teeth. Dental fluorosis, we all know fluoride is protective because it helps remineralize those carious teeth. And we've had a lot of fluoride, fluorosis of general public health water systems since the 1950s or 60s. So fluorosis was a condition that came into play where people started getting concerned with all these fluoride used for preventing dental caries. Are we subjecting our kids to dental fluorosis? And actually, the latest data that I could pick up on dental fluorosis is there was a slight increase in percentages, about 22.8% of prevalence in the 80s, and this is slightly increased to 32% in the 90s to the 2002. 40% of 6 to 11 years old, 48% of 12 to 15 year olds, and 42% of 16 to 90 year olds. Bear in mind that dental fluorosis is essentially a problem of before the age of 7. So it happens when you expose your developing teeth, both your primary and then the uninterrupted permanent teeth to excessive fluoride. So you'll see these typically after the age exposure before the age of 7, but manifestations after the age of 7. So really, where do they get most of their fluoride from? From toothpaste, from drinking water, from beverages, foods, dietary prescriptions, sometimes fluoride tablets, and we talk a little bit about when to give these fluoride tablets, though very rarely do we prescribe them. And other professional dental products, over-the-counter fluoride mouth rinses, fluoride foams, and then what we frequently do, fluoride varnishes. Bear in mind, our water system typically has about 1 part per million of fluoride. When you give them a fluoride mouth rinses, it's about 200 parts per million. Toothpastes have about 1,000 parts per million of fluoride, and then when you do the fluoride varnish, it's a really concentrated resin. It has about 22,600 parts per million of fluoride. So just to have a brief analysis about how much of fluoride they're getting, because that's something you want to do in your oral health risk assessments and your well child visits. So what does dental fluorosis look like? Dental fluorosis is actually very difficult to pick up in the initial stages. It's really a cosmetic problem. You rarely see these nowadays, but the first are little white lacy-like patterns on your teeth. When more than 50% of your teeth are covered with those white lacy patterns, it's moderate form of dental fluorosis. And then when it develops this brown staining, it's severe form of dental fluorosis. The lacy pattern, the mild fluorosis, is very difficult to really pick up. Mostly it's dental professionals or dental hygienists who can really detect this. So in the grand scheme of things, dental fluorosis is not a very major problem, considering it's more a cosmetic issue. Finally, a little bit about oral injury. We have to bear in mind that dental trauma is an important marker for child abuse and neglect. So every time you come across a kid who's kind of misplaced a tooth or a bleeding gum, be a little bit more on an alert for a child abuse and neglect. Especially there's certain kind of injuries that should alert you towards possible neglect and abuse. 30% of infants and young children experience injuries to primary teeth. Most of them is in the toddler age group. They run, they fall, they kind of hurt that tooth. So it's always more commonly normal to injure those teeth, but just hold that in the back of your mind about child abuse and neglect. Certain kinds of types of injuries that they do have is one of the common ones you want to look for suspected abuse is stone frenulum. And it's the upper frenulum. Lift the gum, look for that upper frenulum, and it's typically when force is applied to the face in an upward direction, maybe by the back of the mouth when you give them a smack on the face. So look for that. Injuries for tooth, displacement injuries is when your tooth is displaced. When you typically, there's a condition called concussion of your tooth. So you could hit your tooth, when you percuss on that tooth, it's tender, but there's no bleeding. Those kids, you just have to recommend soft diet for 2 weeks, follow up with your pediatrician, it should be fine. Displacement injuries is not only when they when you percuss the tooth, it's tender, there's some bleeding around the gum, and it's kind of moved away from the socket. So this is an injury. When you see this, you really want to send them to the dentist, because what they could do is actually put a little bit of strip behind these teeth and stabilize those tooths to prevent any kind of malocclusion from occurring later or loss of jaw space. Another kind of teeth injury is an intrusion injury, and what you see in this picture here is actually the tooth is not missing, it's actually lodged into the gum. These are another dangerous kind of significant injury, because you would want to send these kids to the dentist too. What happens is when your primary tooth gets lodged too deep into that alveolar ridge, affects how your permanent teeth erupt. And so you do not want to damage that permanent tooth from erupting properly, so you want to send these kids to the dentist. Most of them, what the dentists typically tell these kids is in the next 3 or 4 months, it's going to self-erupt on its own. 90% of these will erupt on its own. It's the 10% that you are concerned about if there's anything that you want to do to prevent that permanent tooth from being damaged. Tooth avulsion injuries, we're going to talk a little bit about, and really it's the management of what to do with that tooth when it comes off. Something to keep in mind is the electric cord bite. Some of our little toddlers who roam around chew on some electric cords sometimes can develop this burn on the oral commissure. They typically do see a burn surgeon or specialty. But bear in mind that these kids may seem benign initially and maybe just a minor burn, but it can affect your labial artery, and then 4 or 5 days they can come back with significant bleeding. So you always want to make sure that even if it doesn't look severe enough, that you follow these kids closely. So what the consequences of real tooth injury is discoloration of the tooth, but it's again a cosmetic thing, and like we spoke about, it is a problem in the eruption of the permanent tooth, and that's a mild discoloration from a tooth that was injured. So what's the management of the tooth that is avulsed? So typically always tell the parents to hold that tooth by the crown, rinse it under cold water, make sure you specify do not scrub those teeth, because the periodontal ligament that is on the root, at the side of the root, is required for fixing those teeth back in its socket. If it's a primary tooth, and you have to let the parents know not to kind of go and jam it back into the jaw, because that can be very harmful for the permanent tooth eruption. So never reinsert an avulsed primary tooth. However, if it's a permanent tooth that is avulsed, they have to reinsert it immediately into the socket. And follow up with the dentist. And if they're not able to do that, make sure they clean it, hold it by the crown. They do not scrub that periodontal ligament. Make sure they're making that tooth face in front, because oftentimes they come in with the tooth inserted backwards in the mouth. And if it's not possible, tell them to transport it. They are over-the-counter tooth storage solutions, like the Hank's balanced salt solution. But any warm milk, saline, saliva, it serves as a reasonable transport medium for these teeth. And make sure they take the child and the tooth to the dentist once they arrive there. But every permanent tooth which is avulsed needs a referral to the dentist. Finally, wrapping up the common oral conditions, our systemic disease of the mouth, we have to remember that the mouth is a part of a greater, a lot of our systemic disease sometimes just initially manifest in the mouth, so we need to take a better look into the mouth. A lot of our hematological conditions, iron deficiency, anemia, they have the bald tongue, the loss of tongue papillae, megaloblastic anemia, which can have some kind of more predisposed to aphthous ulcers, your dark magenta colored tongues and B12 deficiencies. Some lead poisonings can have what's called the lead line, which is like a grayish discoloration at the gum line. And a couple more common systemic conditions that you can see in the mouth, that initially manifest in the mouth, and you have to look for systemically. So when do you want to which kind of procedures require dental antibiotic prophylaxis? So for infective endocarditis, a common question often is any kind of prosthetic material, any kind of prosthetic cardiac valve or a material that was used for valve repair, if this kid is going in for any dental procedure, will require antibiotic prophylaxis. Any history of a previous infective endocarditis, and the congenital heart disease are only the unrepaired cyanotic heart diseases that would require antibiotic prophylaxis before dental treatment. And it's the completely repaired within the first 6 months. So once it's repaired, it's the first 6-month period is the only time that they require the prophylaxis, and that's for the endothelialization of those vessels take place. And any repaired congenital heart disease with residual defects at the site of the adjacent to the site. Cardiac transplant recipients who then develop a cardiac valvulopathy, if they ever go for any kind of dental procedures, will require infective endocarditis prophylaxis. And it's also recommended for all dental procedures involving manipulation of the gingival tissue, the periapical region of the teeth, or oral mucosal perforations. So having gained a little bit of an understanding of the common oral conditions and abnormalities, a really key emphasis in pediatrics is the prevention of oral diseases. So what is the pediatrician's role? So at the 6-month visit is when you start performing your oral health risk assessments, and we're going to talk about that a little bit. By 12 months visit, every kid has to be examined and referred to a dentist. So at that 1-year-old visit, the visit with the most shots is also the visit that you make sure that you counsel parents to seek a dentist appointment. Typically, they say within 6 months of that erupted first primary tooth, they should see a dentist. Children have to be established in a child's dental care. Research shows that any child who does have a dental home does get better supervised oral health treatments. And per the AAP periodicity schedule, you have to do an oral health exam at the 6-month, 9-month, 12-month visit, the 18, 24, 30-month visit, and then at 3 and 6 years again. So that's again when the primary teeth start erupting. So this is it may not be a little clear from back there, but the oral risk health assessment tool is a little form like this that you could kind of fill out to take into your office and ask mom a couple of questions at these visits. Anything with that little triangle over there are significant risk factor. They automatically put the patient in high risk caries group. So some of the risk factors are mother or primary caregiver. Did she have any kind of active decay in the past 12 months? Ask the mom that if she has a dentist, because if she does not have a dentist, the probability that the child is going to have a dentist is very minimal. Ask questions about continual bottle sippy cup use, frequent snacking, and then pay special emphasis to those kids with special healthcare needs that come into the clinic, the cerebral palsy kids, kids who have multiple comorbid conditions, the NICU grads, because a lot of times in the grand scheme of things, those are the kids where your oral health gets neglected. So peer health to if there's any kind of special healthcare needs in those kids. And do they have Medicaid? Because again, they fall into the lower economic, low economic place where they are more prone to dental caries. Certain protective factors, do they have a dental home? Are they drinking fluorinated water? Have they had fluoride varnish applied? Do they brush their teeth daily? Really simple questions to ask in a well-child visit. And then when you examine, look for those white teeth, white chalky spot marks at the gum line. Look for any obvious decay, any kind of restorations or filling. Once you kind of place them at low risk and high risk, then you can give them guidance about fluoride varnishes, make sure you refer them, and then some little bit of anticipatory guidance. So anticipatory guidance really depends on talking about delayed colonization, brushing teeth, flossing, nutrition, talk about bruxism, non-nutritive sucking, injury prevention, and special healthcare needs children. So about delayed colonization, it really starts with talking to the parent first. As we know that parents can transmit the bacteria to their children, whatever they harbor in their mouth, the strep mutans, often is detected in their children's mouths too. So parents have to be encouraged to brush teeth twice daily, floss, rinse with a fluorinated mouthwash, visit a dentist for cleaning, and have all dental diseases treated. Consume fruit juices at meal times, and there's something about the xylitol that they actually recommend for parents with a high incidence of dental caries and those who have a high threshold of strep mutans in their oral saliva. And what the xylitol really is, it's a sugar substitute. It's just like sorbitol, but unlike sorbitol, when you chew xylitol, the bacteria in your mouth does not break it down into acid, and so it actually helps with remineralization. And also there is research that shows that chewing xylitol decreases your carriage of the strep mutans. The problem with xylitol is actually, if you look at it, you have to kind of tell your parents to chew this thing 3 or 4 times a day. And it's frequently the side effects of it. It's like sorbitol, it causes osmotic diarrhea, a lot of flatulence, so not many people are compliant with this. But definitely it is something that helps decrease the carriage of that strep mutant and decrease the transmission of strep mutants to their kids. So what about prevention of oral disease in the early infancy? Prevention actually even starts before that eruption of that first tooth. So when moms are feeding, breastfeeding, they say actually take a soft cloth and keep cleaning those gum lines after each feed. Lift the lip to brush the teeth at the gum line. And how much of toothpaste is a common question that parents will come and ask you. And it's something that it's simple, but it's to lay emphasis and to prevent fluorosis. Is really at less than 3, before that 3rd birthday, they just get a rice grain amount of toothpaste. It's just a smear size. After the age of 3 and 3-year-olds, they can move on to a pea size, and that's it. It's not about smearing that whole tooth, all those bristles with toothpaste, and that markedly decreases the chances that they could get fluorosis. Another interesting thing they said is to help brush their teeth, and you spit after brushing. But do not rinse after that final spit, because then you're actually removing all the fluoride that you just used on your teeth. It's always nice to leave a little bit of that fluoride in overnight so that it can work on preventing the strep mutants from acting. Kids should always have supervised brushing. The time they learn to independently tie their tooth laces is sometimes linked to the time that they can actually brush their teeth independently. So that's around maybe age 5, 6 is when they can start brushing their teeth, but otherwise it always has to be supervised. A little bit about fluoride. Fluoride varnish is, the emphasis on fluoride really is actually its topical use. Fluoride varnish should be recommended in primary care settings. Every 3 to 6 months in our clinic, we normally do it every 6 months. 3 months is recommended for those with a higher risk on that assessment scale for caries. And we should also mention that fluoride is actually FDA approved only for treatment for carious lesions, not preventative. But there's a lot of research that shows that topically applied fluoride helps prevention too. Systemic fluoride is important because only fluoride ingested during your tooth forming years, and that's really the initial part. It's really in pediatrics, the age 6 months to your 18-year-olds, till that final eruption of your wisdom tooth has the systemic effect of enhancing resistance to later acid demineralization. So it's really the pediatric population that you have to focus on that systemic fluoride use. Fluorinated water recently in January came out with a standardization across the country because there was earlier a range of 0.6 to 1.2. The standardized fluorination of water now has 0.7 milligrams per liter parts per million of fluoride. There is this website that you can actually go to, My Water's Fluoride, and that'll tell you how much of fluoride is in your water system. So when I went into that website for Louisiana and then Shreveport, it depends on where your water system comes from. So the Caddo system is fluorinated with 0.7, but a lot of the Vivian, Mooring Sport, the majority of water systems in the area are not fluorinated. So that was something interesting to see. And so when you know the region your child's coming from, you can always go up to that website and check how much fluoride is in their water. What about fluoride supplements? It's very important to remember, and this was something that was defective in the knowledge-based questionnaire that was handed out to pediatricians earlier. It's only applicable for children greater than 6 months and those who had high risk of dental caries. Over-the-counter fluoride mouthwashes, sometimes parents come who are more on the precaution-based aspect may ask you about these, but they're generally not recommended for kids younger than 6 years because they could swallow that and higher risk of dental fluorosis. How much of fluoride does our water have then? A lot of us are moving towards a lot of bottled water, just easier to consume. And so this is from the most reliable site that I could find, which actually went and emailed and interviewed these various water bottling companies to find out how much of fluoride is in the water. And what they really came out with is not many of them reach the 0.7 milligrams per liter part per million amount. So a lot of the bottled water is actually non-fluorinated. The FDA does not require that the bottle label does have whether this bottled water is fluorinated unless you add fluoride after the purification process. So if the bottled water is coming from groundwater that is high in fluoride, you do have, it would have some traces of fluoride, and that's how they have these rating scales of how much they do. But once you purify water, if you're adding additional fluoride, that's the only time it shows up on those bottle labels. So a lot of our bottled water is not fluorinated. So as far as systemic fluoride use and recommended doses, and I was talking to Dr. Bienvenu in the clinic, and he said in the past 12, 15 years, he's never ever prescribed systemic fluoride. So it's rarely ever do you prescribe fluoride supplements, but it's something to know that you could do. Newborns to 6 months, it's never, regardless of the risk factor, regardless of the amount of fluoride in that water, they never get any kind of systemic fluoride supplements. The age of 6 months to 3 years, it all depends on how much of parts per million is in their water. Now, Shreveport, we all have 0.7 parts per million. None of them would really require it. And then it's the amount of the doses, depending again on their fluoride concentration in their water. So really, it's the 6 months and above, and those kids at the highest risk of caries that you may want to consider fluoride supplementation. Fluoride varnish, a quick word about it. We all know we've started doing that in our clinic. We start at 6 months, do it every 6 months. The code has changed for the billing. It used to be a dental code earlier, now it's a medical code, so it's a 99188 to get reimbursed for it. Medicaid does reimburse for it. It reimburses for 2 fluoride varnishes in a year. It really leads to an average of 33% reduction in decayed, missed, and filling tooth surfaces in the primary teeth, and a 46% reduction in permanent teeth. So it's a significant reduction in caries by the simple procedure of applying this fluoride varnish to teeth every 6 months. And fluoride, like we said earlier, helps remineralize those dental caries and decrease the demineralization. The application frequency could range from 2 to 6 times a year, depending on how bad those caries look. There was this research article done by Wintraub et al. In San Francisco, where they took about 300 children from the Hispanic Chinese community, and it was a randomized control trial. The dental physician was blinded. All kids, and it was for kids with no dental caries at all, less than 6 years. So these were benign, normal, healthy-looking kids, oral cavities. They came in and put one group in just for counseling. The other group received both counseling and then fluoride application once a year, and the next twice a year, and then some of them received the counseling and fluoride application 3 to 4 times a year. And what they realized was that a lot of kids who received just the counseling, the incidence of the caries was about 45%. So definitely fluoride varnishes does help decrease the incidence of caries. Dental sealants, a quick word about that. Dental sealants are really applied to the pits and fissures of molars. 90% of caries do occur in this. What you need to remember about dental sealants is it occurs on the permanent molars, and that's a picture of it. You could ask kids who have the permanent molars erupted that's another way that they could prevent dental caries. Finally, anticipatory guidance, the do's, don'ts that we had really gone over. Encourage breastfeeding, encourage them to clean those gum lines. Try to stop the night feeding once the teeth erupt. Delay introduction of juices until at least 1 year of age, and even if they do, it's just limited to 4 ounces. And it should be from a cup, no juices in bottles, because that is known to increase caries risk. Try to eliminate the bottle by 1 year. So at that 1 year visit, when you're talking about the dentist, make sure you're talking about eliminating that bottle too. Snacks that are less cariogenic, substitute sweet sugars, sugar-filled snacks and candies with fruits, vegetables, cheese, milks, carrot sticks, something more healthier, which would help with our obesity epidemic too. Again, like we spoke about the 3 meals, 2 snacks, no grazing. We want to keep that pH at 5.5 to prevent that demineralization of those teeth. And it's also a good time to reinforce protection of the teeth if they are into any kind of sports, use of helmets, mouth guards, things that you should kind of talk to them about. About the don'ts, don't test the temperature of the bottle in the mouth. A lot of moms kind of try to do that, but they don't realize in the process of doing that, they're transmitting the strep mutants, the cariogenic bacteria from their mouth to their children's mouth. Don't share utensils, don't share spoons. A lot of our kids, they clean the pacifier by putting it in the mom's mouth, or the dad picks it up and cleans it, but that's another very common way of transmitting these bacteria. Definitely don't put the infant to sleep with a bottle or sippy cup. Don't allow frequent and prolonged bottle feeding or use of sippy cups with sugary beverages. And finally, never prop a bottle in bed or in the car seat or whenever. So really, my final slide is really a conclusion, and this was from an article which said really the top 6 tips for pediatricians to ensure children's health is, if you're not familiar, learn how to assess oral health in children. There are a lot of good websites, Smile for Health, Impact, the AAP has a whole learning training module for children's oral health. So become familiar with it, recognize the risk factors, do the risk assessment that contribute to poor oral health. A very, very important part is to kind of get to know who our dental colleagues are in the community and establish a partnership with them, and include anticipatory guidance on all your well-child visits, even before that first tooth erupts. So really be a true advocate for oral health children in your local area. And that's it I have.